diabetes is an example here in Hawaii, where we have a high prevalence of diabetes. So just looking at disease management for that alone, certainly it makes sense that we
Professor,
realize
you're on
savings.
the director or the board of directors of the Department of Health. Is there anything relevant that we can apply here in the state of Hawaii in terms of
Sure.
not mandating, but persuasively suggesting certain things?
Yeah, I mean, I think when we look at prevention, I think prevention really is the key, and I think this is where government does play a role in the healthcare. Is that if you're looking straight at a cost containment, it might be cheaper to have somebody smoke and die earlier than it would be to get them to quit smoking, but it's obviously not what we want from a public health perspective. And so we really do need to look at that. And I think one of the difficulties is things like, we know obesity rates are increasing in the nation, and it's hard for physicians to get reimbursed for counseling patients to change their diet and get more active, but a gastric bypass is covered. Right? And so do we want to give gastric bypasses, or do we want to get people more active? I mean, these are major questions that we need to look at in the reimbursement system for physicians. We did get smoking counseling added, so that smoking cessation counseling added, so that is reimbursable now. It was a big step. It's something we worked through the Coalition for Tobacco-Free Hawaii on getting that included. And actually, you talked earlier of what is Hawaii doing well. We've actually done very well in a lot of the prevention areas, and so we put a large percentage of our tobacco settlement money into primary prevention, so the Tobacco Trust Fund and the Healthy Hawaii Initiative through the Department of Health, which does physical activity, nutrition, and tobacco use. So we have one of the lowest tobacco use rates in the nation. We have one of the lowest rates of obesity in the nation. And so we're actually really doing well in prevention, and it's been just about 9-10 years now since we've put that tobacco settlement money towards those things, and you're starting to see a lot of the payoffs. Now, it's a piece, and obviously there's a lot that needs to be done, and more integrating with the healthcare system. But as we were talking about earlier, I think what's nice is Hawaii is small enough that we can see this integration. At the university, we've been seeing a really nice partnership now between the Cancer Research Center of Hawaii, Queens Hospital, and Hawaii Pacific Health, and really looking at how do we provide comprehensive cancer care that includes the research, it includes the hospitals, and how do we do this appropriately so we're not competing with each other. There had been a model to try to build a separate cancer care center for the university. We said, no, let's work in partnership, because there's only so many cancer patients, and let's provide the appropriate care at the appropriate institutions. And that's been working really well, and it's moved forward fairly dramatically in the last year or so. So those are some of the wins that we're starting to see.
You mentioned obesity, you mentioned
tobacco.
The tobacco incidence, the diabetes. In the countries that are healthier than the U.S., what is their incidence of those in terms of what percentage of the U.S. is obese versus those countries that you said live 2 years longer?
Sure.
Versus the causality being the healthcare system is the one that makes them live longer versus the lifestyle.
A lot of it is lifestyle.
Smoking
now,
and eating, drinking.
Our tobacco rates tend to be lower than a lot of places, actually. Tobacco is one of the major public health successes in the U.S. We've seen just tremendous drops. In Hawaii, it's around 15-16% of adults now that smoke, which is...
In Japan, I know it's 40%.
Japan is 40%, right. In Japanese have a very long lifestyle. So Japanese, obviously, it's more the diet and the physical activity. Every country is different, and I think it is a mixture. And I think one of the things we really need to do is re-envision healthcare to be healthcare and not sick care. And I think that really is a major focus.
That's the way to describe what you said, turning it upside down.
Right.
Turning it upside down and
Right.
focusing on public health rather than on acute care and long-term care. If we can prevent those illnesses, that's where we make the change. But it's tough. We're the one school of public health at the University of Hawaii that was ever closed. And the state hasn't reinvested in it. And it's I'm always asking why, because I think that's where we see so much savings and so much of a difference is that the front end and the quality of life also.
I remember that well, particularly I used to work at USAID and public health and all the stuff that was going on, tropical diseases. Hawaii was the place to go, and then shutting it down, and that is a bit of a surprise. Speaking of shutting down, you mentioned humorously that, well, just let them smoke and they'll die off and it'll be cheaper. I'm going to say my first controversial part of this whole interview. Somewhere in this 1,017 pages is end-of-life counseling that was misinterpreted or called death panels. Have you guys read it or know what's in there? So people are wondering about, hey, we've been reading about death panels. What really is in that thing that says end-of-life counseling? And if it's in there, why is it in there? What does it do?
Sure. I'll share with you what I understood from listening to an NPR broadcast, actually, where there was someone who had been interviewed talking about the content. And we work with hospice providers who also provide palliative care, which is supportive care, pain management. But my understanding is that it would just enable patients to have access to a provider or physician that would offer counseling to them about living wills, what is hospice care, how do you access it. There's something that just recently passed here in our last legislative session called PULSE, which is Physician Orders for Life-Sustaining Treatment, which was actually replicated at a federal level that would link the physician's payment for those services to PULSE. So my understanding of what is included in there, although I haven't seen the exact language, is that it's a comprehensive counseling opportunity for a patient so that they have someone they can dialogue comfortably with about end-of-life care. In Hawaii, because of our cultural composition, it's a topic that is often difficult to broach. So they may not be able to talk with their family about it, but it at least enables the opportunity for them to have this through.
And it's a healthcare option.
Correct. That's my understanding.
Is that your same understanding?
That's my understanding. I think it really, in America, so many of us don't believe that we're ever going to die. And I think, as I was talking about right in the beginning, is those last 6 months of life are so expensive and are often horrible because we're going through, extensive surgeries and treatments to, prolong life. And I think people don't often think about the hospice option and sort of saying, maybe it's my time. And so this opens up an option to say, what's the right choice for me? And I think it's not mandating to anybody, you got to go to hospice, we're going to cut off the treatment, but saying this is a viable option, and it might be, a much more enjoyable way to spend your last, few days on Earth.
You have each 15 seconds for a closing comment on this 1,017-page bill. Any summary bumper sticker comments that come to mind?
Well, the Healthcare Association of Hawaii looks forward to continuing to dialogue with our delegation and our national partners in ways that we can address Medicare payment reform. For us, it's absolutely essential that we look at payment options for providers that enable them to continue to provide care. And appreciate the opportunity to be here.
Okay.
Dr. Maddock?
I think we need three things. We need universal coverage, we need good public health prevention programs, and we need cost containment. If we can get those, we've got a good health care bill.
Those are the targets, and just like our bodies that don't last forever, this program doesn't last forever, and it's already time to say aloha. Thank you, too, for adding to the intellectual grist of the mill for what otherwise has been a very confusing, lacking, not full understanding, but you've helped clarify, particularly regarding if the program does come to Hawaii, we will have had a program that could stay in place, in situ, regardless of what goes on at the national level. That's good news for Hawaii. Thank you for seeing and viewing Better Government. I'm Representative Gene Ward. Aloha until next time.